Okay. Um, okay. Dear friends, we must start our webinar today. We had technical problems in the last webinar trial. I will present you Dr. M.Tariq Imtiaz, who is a very well-known person from Saudi Arabia. He's originally from Pakistan. He will tell us the neuromonitoring options in spine surgery. Yes, Tariq, we listen you.
Okay, thank you very much, Professor Zalili. Assalamu alaikum. Good evening, everybody. And I really want to apologize for the last time because I tried to prepare everything, but at the last minute it turned out that we were not able to play the presentation from where I was. Anyway, so let's start. So the subject line is intraoperative neurophysiology in spine surgeries. It's a very big topic, but I'll try to take you guys slowly. So I'm sure a lot of you understand already. But there are some minor things, some surgeons may have questions, or even the physicians or the technologists who are doing intraoperative monitoring. They may have a few questions. So let's discuss a few questions. And towards the end, we will share our experiences or questions. So the objective of this talk is following. As you guys can see. Am I going too fast, Junaid? Please let me know. Can you see the screen? So it's number one, is the idea for spine surgeons to have a better understanding. And then what modalities or what tests are we doing these days in spine surgeries? Remember, this talk is specific to spine, so I'll discuss only spine. And then I'll show you some of my cases with videos and images and a little bit of data. And then towards the end, I have a brief recommendations for, especially for new guys, or new people or new surgeons who have started monitoring, using monitoring, or new technologists or physicians who have started doing monitoring. Okay, so this is an educational talk and not a research-based talk, so the crux of the matter would be to educate you guys. Now, this is a very important thing that you guys see now. The cost of disability is really high in developing world. We know that monitoring has been used in developed world, in Western countries, in the US, Canada, Europe, but not much monitoring has been used in Asian countries or underdeveloped countries. There are a few centers who are doing this, but this is important to remember that in developing world, if a patient gets paralyzed by something that was preventable, the cost of disability can be really high. And this is coming out from the UN report on disability that came out 2 years ago, where they mentioned that the cost of disability can be really high. So especially in developing countries, there is a need, not in all cases, I would agree on that, but in some cases to use intraoperative neuromonitoring. I'll go to the next slide. So what exactly is intraoperative neurophysiology monitoring? Briefly, it is a use of certain tests, as I said, certain modalities, to prevent injuries, to identify injuries immediately as they happen. So there is time to do reversal or time to do certain measures. And that in the end helps in the maintenance of the functional integrity of the neural system. During surgeries, it's real time. As the surgeon is operating, you can get data immediately. And I'll tell you the time frame, how long does it take during the course of this lecture. Now it allows surgeries on more complicated cases, medical legally, even in Saudi Arabia these days, medical legally, litigations are coming up and becoming a problem. So if you have monitoring available, if you're not using it, that may be a medical legal liability. The very important, I know a lot of experienced surgeons perhaps can do very good surgeries without monitoring. But you need to understand, if you have a neurosurgery residency training program with spine surgery or neurosurgery or peripheral nerves, or even other cardiothoracic surgeries where monitoring has limited use, your residents would really learn faster. because they would be notified immediately the things that changes the data, and they would learn it much faster. So those surgeons who are very comfortable without monitoring, I'm sure for their teaching and training program, monitoring is extremely beneficial. I'll go to the next slide. This is a slide I would like to share. If you see some of the accredited laboratories these days in the world, most of the accredited laboratories are in the US. In fact, all of them are in the other countries may have different systems of their own accreditations, but we are the only hospital, if you see on the top left in purple, King Fahd Medical City is the only hospital outside of the US that has an accreditation, and that is an accredited intraoperative neurophysiology lab. That is my lab accreditation about 5 years ago. Now, certain things to remember, you know, in this slide I would like to answer. Some surgeons may have questions that, you know, my technologist stopped me prematurely, or sometimes he did not stop me and patient woke up with deficits. You know, there are certain reasons for that, and those are not much clinical reasons. Those are technical reasons. Every surgeon, as a surgeon or as a resident, or if you are a physician or a technologist, you should need to remember these two things: stimulation parameters for a neurophysiology test, and then recording parameters. Now, each of these stimulation parameters, where are you stimulating? You see on the right of the screen, you have intensity, pulse width, repetition rate, and interstimulus interval, we call it ISI, and then recording parameters where you have montages, frequency, bandwidth, latency. These understanding of these technical parameters are also very important to get good data and to identify changes promptly. I'm not going to go into those details because this is a sort of talk for surgeons, but a good understanding of these things matters in your correct acquisition of data and then reporting and reading of data to the surgeon. But just remember these things: stimulation and recording, and they have their own parameters. Now, a couple of things before we go into the real part of my talk. I'm sure most of you guys already know. Besides stimulation and recording, two terminologies that is very commonly used: what is monitoring and what is mapping. Mapping is used mostly in brain cases, brain mapping, where you do not know, you have an idea that this is that particular structure, but that particular structure you don't have an evidence or enough evidence. For example, motor cortex that has been obliterated by a tumor, a recurrent tumor, a GBM, or a glioma, or any other tumor, and you want to, or even in epilepsy cases, for example, and you want to exactly identify what spot is the motor cortex, where is central sulcus, where is sensory cortex, and then on the motor cortex, which is the hand area and which is the leg area, specifically with that. You can do that by identifying those isolated individual, you can say landmarks or tiny points. And monitoring, you have an established system, and you're testing those established system, for example, somatosensory system or motor cortex, motor system, and you are getting signals by stimulating somewhere and recording somewhere. So mapping is not monitoring. Monitoring is not mapping. Mapping is used in different cases. Sometimes we use mapping in spine cases as well. I'll briefly describe to you. Now, one thing everybody should remember, as a surgeon also, surgeons should remember that if you have a patient with a really bad McCormick scale, for example, McCormick grade 3, likely McCormick grade 4, those patients' acquisition of data is a problem. And those patients, you may not get good data, or you may not get good acquisition of signals to proper interpretation of the data, So far, what I'm trying to tell you is that if you have a grade 4 patient, that'll be, you need to have a very experienced physician and the technologist who knows how to play with those parameters, which I previously showed it to you. And then only you can identify data. So, you know, sometimes you have problems during acquisition and you are like, what's going on? So that is the problem with those parameters, that the technologist is not experienced enough, or he does not have the understanding of those parameters. Now, one more thing I would like to tell you in this slide is that if you have, during surgery, if you, you may expect that the patient may present to you post-op with the McCormick grade 3, although your technologist would tell you that, you know, I lost the signal and there are flat lines in motor evoked potentials. flat lines in motor evoked potentials in a spine case does not mean grade 0. So please remember that. If your motor evoked potentials drop during a spinal cord tumor, it does not mean 0. It may mean 0. There is a little bit of limitation in our signals. If I told you that the signals have completely dropped, then you may expect a power 3, power 2. Discuss this more when we go on. So what are the expectations of surgeons to use IOM? What they want to know. So these are some of the questions. They want to know, where's my screw? And I'm talking about spine only, although half of our caseload in Riyadh, Saudi Arabia is brain cases. Maybe another talk I'll talk to you about brain cases in neurophysiology in brain. So some of the things, if we can we prevent injury? In some cases, yes, we can prevent injury. But in almost all cases where there is an injury, we can at least do this part, that we can immediately identify that injury and tell this to the surgeon, and he can reverse the procedure, he can undo the last step, we can add certain things like increasing mean arterial pressure, giving steroids, or keeping the mean arterial pressure for high means 80 or 85 or 90 millimeter of mercury for a good period of time after surgery as well, and that helps. And there is enough data that is telling us about it. But if you missed it and you did not tell the surgeon for 10 minutes, you have missed the window. So I'll tell you how we are able to identify those changes immediately as we move along. Now, what modalities are we doing in our hospital? What spine surgeries? These are the spine surgeries we are doing in our hospital in King Fahd Medical City. As you can see, there are cervical cases, thoracolumbar cases, scoliosis, takes the most part in our spine cases, and then I label them as advanced spine surgeries, where we need to have more knowledge of electrophysiology and the modalities to be able to correctly do these cases. For example, spinal cord tumors, and then AVM malformations or selective dorsal rhizotomies. Unlike most of the Western countries, probably in the US, I think every case is monitored. Where instrumentation is applied. Sometimes some surgeons even do discectomies and they monitor them, I think probably for medical legal purposes. But in our hospital, we are only monitoring very limited cases where instrumentation is used, not because we don't want to, it's just because we have so many tumors and some other cases that we have to pick and choose. But in general, in spine surgeries, these are the surgeries where around the world monitoring has been used. Now, what modalities are being used currently in intraoperative monitoring for spine surgery, specific to spine surgery? These are the modalities that I have highlighted for you, and we will briefly discuss them as we move along. Somatosensory evoked potentials for upper limb and for lower limb. As you can see, the name says it's a somatosensory response to the dorsal columns. And remember the two things I talked to you about, stimulation and recording parameters. So you need to remember that. We will get to that part in the next couple of slides. Transcranial motor evoked potentials. Please remember that if you're not doing this test, you're not giving your surgeon complete security regarding the signals. If you're doing only somatosensory evoked potentials, and then the number third, you have EMGs, I've written that, and then you have mapping for D waves and spinal cord mapping for some of the tumors. You must do transcranial motor evoked potentials in all cases. If you're doing it without transcranial motor evoked potentials, and I'll show you with my own data that it's not enough for the surgeon to be secure during this spine surgery. EMGs, you guys already know. The triggered electromyogram is something where you stimulate. EMGs, or number 3 point I'm talking to you about, is the spontaneous response from the muscle. You put your needles in the muscles, relevant to the surgeon. For example, if he's working on the cervical spine, you do some cervical roots relevant to his levels. For example, if he's working on C5, you do deltoid EMG, biceps EMGs, and maybe brachioradialis. And what you do there, you place your needles or electrodes on those muscles, and as the surgeon is working around the cord or on the roots, certain responses are generated because of mechanical irritation, and your muscle would produce a CMAP, and that would be recorded, or your muscle would fire with fasciculations or fibrillations or some discharges that may be very severe. And you tell the surgeon that this root is getting hyperactive. So what we do there is we just tell the surgeon to use some cold irrigation, and the roots settle down, and then he resumes again. But what is triggered electromyograms? Triggered electromyograms is when you try and give current to a particular root or a structure, and you ask that structure to fire and produce a CMAP. You create a CMAP by giving current. That is a triggered electromyogram, and I'll tell you a little bit more about it in the next few slides. In direct nerve stimulation, it's very simple. Spinal cord mapping and spinal cord motor and sensory mapping. I do that in our cases where we have spinal cord tumors. We get a lot of spinal cord tumors because we are the largest tertiary care facility in the Middle East, especially in Saudi Arabia. So we have abundance of referrals for motor cortex, for the spinal cord tumors, where we do sensory mapping for dorsal columns identification before the surgeon starts myelotomy. And I'll give you a case as well. I have a very nice video of that case as well. And then D waves. D waves are basically motor responses, but you acquire those responses from the cord, not from the muscles. It's just like a motor evoked potentials, but in motor evoked potentials, you stimulate a scalp and you record from muscles. In D waves, you stimulate proximal to the tumor and you record distal to the tumor, but within the spinal cord. Those are D waves, and there is advantages of D waves. Labeled here electroencephalography. And I'd love to do EEG in all cases. In fact, that's my practice in my hospital. And the reason I am telling you the EEG is very important is because anesthesia sometimes changes the anesthetic drugs that they're using. And if the surgeon is at the critical stage of a surgery, use of a bolus, for example, may reduce your signals. And you may, you may tell the surgeon without knowing that there is a drop. And he would think that, oh, this drop is because of him. But it may be a resident of anesthesia who may have given a bolus because, he felt the patient was light and he may have given a bolus, or he may have given inadvertently muscle relaxant, or he may have started the inhalational anesthetics, which we do not want. We want only total intravenous anesthesia to be accurately able to monitor signals. So EEG is very important, and it's my practice to do 4-channel EEG in all my cases, regardless of spine or brain or some of the other cases. So these are the modalities that we must do. But of course, you can see that 1, 2, and 3, 1, 2, 3, and 6 we do in almost all spine instrumentation cases. And number 5 and 6 are reserved for only tumors. Go to next slide. So, and what criteria are we using for identification of a change? We have guidelines from American Clinical Neurophysiology Society, and the SSCPs, we have 50% drop in the amplitude. Amplitude is the size of the wave, and I'll show you in my next slides, and 10% drop in latency. You can see that in EMGs, I already discussed that. There may be some initial burst that happens because of irritation on the nerve, and then there may be train of discharges, which is another severe form, and then neurotonic discharges, which are high frequency, high amplitude discharges. And if you keep that discharges to continue, this nerve root may result in a transient weakness post-op. So you need to identify these things and tell this a surgeon and do necessary measures. And then TCMEPs, in spine cases, they say that TCMEPs or transcranial motor evoked potentials, the surgeon can continue until he's seeing even a small response. In brain, it is different. So there is not really a consensus on the real threshold criteria to stop surgery in spine cases. But in general, 50% drop of signals in TCMEPs is considered to be a severe sign. But in our hospital, we do not. We, of course, identify the change as it happens. Remember also that you do not wait for the 50% drop to happen. You communicate with the surgeon as they happen. And you always try and correlate those changes with the step of the surgery. You see where the surgeon is. If the surgeon is not even on the cord and you are telling him, oh, there is a 50% drop, you are basically destroying your rapport with the surgeon, because he's going to tell you that, oh, I'm not even on the cord. I'm just exposing. So you need to understand that where the surgeon is. You need to understand all the factors happening, for example, as I just mentioned, anesthesia, and then correlate those changes to the surgeon. And then direct nerve stimulation, a healthy nerve, just keep that in mind, a healthy nerve. If, for example, if you're doing a tethered cord case or a quad-actina tumor, where you may want to map the nerves and which nerves are which in the cauda equina if you have a big tumor. The healthy nerve is, when it's stimulated, it produces a response at 1 milliampere or less. But if you are having, if you're stimulating a nerve and the nerve is producing a response higher than 1 milliampere, you would know that this nerve is probably pathological, and this nerve may still be intact, but the conduction may be bad because of diabetes or because of chronic compression or because of CIDPs or polyneuropathies or other diseases. So, and then stimulation for screws. A healthy screw gets stimulated at 10 milliamperes or higher. So generally we do screw stimulation in thoracolumbar scoliosis cases or lumbar fusion cases. And when we stimulate the screws, and I'll tell you what is the method of stimulation in the next slides. But generally, if you stimulate a screw, if you're getting a response relevant to the screw level, for example, the screw is left L4, you should get a response on left quadriceps femoris on higher than 10 milliamperes when you give a current. We'll get to that part. Below that, you may have gray area. In my practice, if I'm seeing a screw being stimulated at say 6-7 milliamperes on a thoracic level, I always see the motor response for that particular muscle where I'm seeing a response at less intensity. And I always communicate with the surgeon how good was his purchase. When he was placing this screw, was it a good screw? Or did he feel like the purchase was not very good when the screw was going in? If he tells me that, yeah, I did not really feel comfortable, I would tell him to reposition the screw. There may be sometimes, maybe a debate in this test because this test is super sensitive. Sometimes it gives you a response on less current, even though the surgeon would tell you that he is perfectly fine. He was absolutely comfortable with the screw placement. So that's why I would like to suggest to you guys that always see the motor response from that muscle and then tell the surgeon, how good was the purchase. Let's move on to the next slide. Again, the message is you do not wait for 50% drop, you communicate. Even if you're seeing a change, 10% change or 20% change, you communicate that I'm seeing a pattern developing. And of course, you need to correlate that with the step of the surgery, and you need to have a good rapport and communication with the surgeon and anesthesia, both in the room. All right, so what is somatosensory work potential? I have this from my own, pictures or animations, you can say. As I told you in the beginning, you can see there is stimulation, there is recording. In somatosensory, we like to stimulate periphery and record the signals as the signals go up in the peripheral nervous system and entering the central nervous system from the cord or from the thalamus or brainstem or from the brain itself. So there is stimulation in the peripheral nerve. So we have stimulation electrodes, as you can see in the picture. And then we have recording electrodes on the scalp. As I told you, we can have recording electrode and the brachial plexus, or from the brainstem where the circle is, or from the scalp where we have recording electrodes. So stimulation is in the peripheral area, in the nerve, the median nerve, ulnar nerve, radial nerve. This is upper limb we're talking about, and the recording is on the scalp. So, and you can see as the signals go up, the signals that reach brachial plexus around 9 milliseconds, that is, we call the latency. The time that it reaches a particular point is called latency, and the response is there is a wave or morphology that is being formed. We call this an amplitude. So we measure the time and the amplitude, then the response goes up to brainstem at that particular time, and then the response goes to the scalp. This is in an healthy adult male. So you can understand if the surgeon is working on the cervical spine, if you're seeing that 9 millisecond response is still at 9, and the 13 and 20 millisecond responses are being delayed, you know that this is happening because of the surgery, because your peripheral response is still okay. So I hope you guys understand that. Then the same way we do, here you can see that, there we have recording electrodes and then stimulation electrodes. Same way we have stimulation and recording electrodes. We have about, in the adult male, it takes about 37 milliseconds from the stimulation of posterior tibial nerve in the ankle to record at the scalp, about 37 milliseconds. If the patient is a tall patient, it may take longer, but in general, you get these baselines before incision, and you compare throughout the case, these baselines or these numbers and then these amplitudes, and you tell the surgeon based on the changes that you see. Similarly, motor work potentials, where you're stimulating. Remember, in sensories, you were stimulating in the periphery, recording in the central system. In the transcranial motor work potentials, you're stimulating in the scalp, and through the scalp, you want to stimulate the motor cortex. And then you can record anywhere, you can place electrodes based on the need. For example, if the surgery is in the cauda equina, You might want to record from the lower limbs. If the surgery is in the cervical spine, you may have your recording electrodes going into the upper limb as well. So I hope you guys understood. Stimulation, recording, and sensory and motor, there is a difference. It's a very simple difference. I hope everybody understands based on the anatomy. Let's move on. Screw stimulation. Let's quickly go on. Look at this screw. Now, I would like for you guys to understand, I would like you guys to understand what happens here is, if you see on the bottom left picture, there is a screw going in and there are two red arrows. What happens is, when the surgeon places the screw, which you can see on the top left two pictures, when the monopolar stimulator, the surgeon puts that stimulator on the top of the screw, and then from the machine, or your physician or technologist gives current on a particular parameters of, again, stimulation and recording, but normally he gives current up to 10 milliamperes. And if there is a breach during screw placement, for example, a medial breach, most likely a lateral breach would result in root may get inadvertent injury or irritation. And what happens is the current follows the path of least resistance and the current exits through that breach. So for example, if there is a big breach on the lateral aspect of the screw, what happens is that the less current, as you give current from 1 milliampere, say you increase to 5 milliampere, at 5 milliampere the current may exit through that breach from the screw and hits the nerve fires, and that nerve is going to, say, quadriceps muscle. You record a muscle action potential from quadriceps femoris. And then you tell the surgeon, oh, I got a response at 5 milliamperes. What is happening? As I told you, this is what is happening. So what happens here is, if you do not have a breach, you keep on increasing the current, and the current does not exit. And then eventually, since you are increasing the current, and the current eventually spreads, and it then hits the root on a higher intensity, and that is not really a bad screw. So what in the beginning, when I told you guys that a lumbar spine level, a healthy move, anything higher than amperes should be considered a good screw, but less than 10 milliamperes, you need to communicate with the surgeon. If you have a response of 3 milliamperes, that is really a bad screw. The surgeon must insist on replacing or repositioning that screw. But if you're getting a response, say at 8 milliamperes, you may want to ask the surgeon that, are you sure you had a good purchase? And if he says yes, see if your motor responses and EMGs in that muscle were good. If they're good, keep it. Because there's still some debate going on in this test, and that's why some surgeons do not use this test. Let's move on. These are some of the examples. You can see in the bottom right picture, the screw is out laterally, and that screw may be hitting the nerve, and that nerve may be firing. So when you stimulate this screw at less current, this nerve will fire because that screw may be touching the nerve. So the nerve would get current, even less current, and that nerve will fire, and you will get a response at less current, and you might want to tell the surgeon that you need to reposition it. Here are some of the examples of some of the good or bad screws. You can see that the screw number E may produce a really low screw stimulation test. A and B probably would not. Also remember that the screw stimulation test is good for lateral breaches. If you have a medial breach, likely the signal that would show you changes would be motor signal, not the EMG signal. Remember, the screw stimulation gives you EMG signal. So you need to understand that concept as well. If the surgeon is going medial, you may not see a screw response on less current, but instead you may want to look for motor potential changes if the cord is really being affected, and if there is a hematoma or sometimes an injury. So these are some of the examples of EMG variations. As you can see, the top left is the deltoid. If you can see, all this are left side muscles and right side muscles, and you can see this there's a little blip on this pink top. This is just a fasciculation, not really serious. And on the bottom left green one, you can see there's a train pattern developing. Just like the train path, there is a pattern developing which is not good. It's not bad either. You just want to communicate to the surgeon, I'm seeing some irritation. And see the bottom green one is not really bad. But if you see on the right side, the frequency and amplitude of these responses, if you see this, the second top right blue one, it's getting bigger. So that's where you may want to ask the surgeon to use, to proceed with caution, and or use. In my practice, if I start seeing this to happen, I mean, this continues for 10-15 seconds, I just ask the surgeon to use cold irrigation, and most of the time it will go away. But if this persists for too long, you may have motor reward potentials dropping in that particular muscle group, and that particular muscle group you may have post-op transient weakness. So you need to be able to understand that. All right, so let's just discuss some of my data from spine instrumentation cases, just briefly. The top picture, if you guys can see, the higher the number of, or the more multiple levels of vertebral surgery doing, the likelihood of a motor change is higher and higher. Comparing it to the second part or the picture below, where you're seeing the sensory drops, somatosensory changes are much rare. So as again, proving my point when I told you guys about motor evoked potentials, you must do motor evoked potentials in all cases. As you can see that the motor evoked potentials are more likely to be affected in a spine case than somatosensory evoked potentials. In fact, I can tell you this, so far I have done about 250 scoliosis cases, and I have not seen a single somatosensory evoked potential dropping in lower limbs in 250 scoliosis cases, at least in my practice. We have seen, some sensory drop when there is a motor drop, and if there is an injury is very severe, for example, a big medial breach or the screw has gone in medially, that may result in motor drop immediately, or that may result in a sensory drop along with motor drop. But isolated somatosensory evoked potential drop, I have not seen yet in scoliosis cases in my practice, in 250 cases in my current hospital. We have seen somatosensory evoked potential drop in other lumbar cases, but I'm just giving an example based on number of levels. So you have multiple levels involved. Likelihood of motor change is more than the sensory change. These are the type of changes that we have seen in about 200 patients of, this is from the scoliosis data. And you can see that positioning change, 5 patients out of 200 presented with positioning changes, positioning in the upper limb or positioning in the lower limb. Sometimes, the upper limb is stretched too much at the brachial plexus. When you have an upper limb going up, that may result in a post-op right upper limb and left upper limb changes. As you can see, a very important thing is 12 patients presented with anesthetic changes. What does that mean? This means that the changes that I saw was actually not because of surgeon. Was because of anesthesia. For example, a blood loss that anesthesia was not able to rectify, or for example, the mean dropped, and because generally, anesthesia are very good people, but generally what happens is their concern is not spinal cord perfusion. Their concern is mostly heart and keeping the patient under anesthesia and sleep and not being able to feel the incision and all of those things. But they're not much worried about spinal cord perfusion unless you tell them. For them, a mean arterial pressure of 60 millimeter of mercury may be good, but for you may not see good signals at mean arterial pressure of 60 millimeter of mercury. So you may want to ask them to increase the mean arterial pressure. So these are the changes happening because of that, not because of a surgical insult. And as you can see that we have about 48 patients where some injury happened, either lateral or medial, and then this 33 is specifically in about 200 scoliosis patients where at least one screw went lateral, and you saw changes happening in EMGs or triggered EMGs. Again, just to show you the comparison between motor evoked potentials and sensory evoked potentials, if you can see this, that I had in 200 patients, about 58 patients presenting with some sort of motor evoked potential drop. Remember, I'm not suggesting 100% drop. It may not be a clinically significant drop, but in my practice, anything above 25%, I start worrying a little bit, not bothering the surgeon. I just go to the anesthesia, ask them to change the mean, increase the mean, and if there is a blood loss, significant blood loss, just try to anesthesia to be on their toes. But just to show you, 58 patients presented with motor evoked potentials, but the real bad patients are these 18 patients where motors and sensories both drop. Remember in the previous slides, I told you that I have not seen a single lower limb somatosensory evoked potential drop. So these are 18 of the patients where somatosensory also drop along with motors. These are the patients likely going on, presenting with the post-op deficits that may be transient or maybe even permanent if you guys do not recover or you do not do things on time. So this 200, and if you see 18 patients out of 200, it's about 10% or 9% patients that may have scoliosis in our practice. But if you count these 58 motor evoked potentials that we do certain things without really notifying the surgeons, we are quietly contributing to the success of the surgery without surgeons actually knowing it. So again, the emphasis is you do multimodality with both somatosensory and motor evoked potentials in all spine cases. Now, a lot of people ask me about EMG. To be honest with you, EMG is not a very sensitive test. It picks changes, but a lot of time minor irritation may not mean to irritation. Surgeons would like to know even there is a slight irritation, but don't bother surgeons too much. If you know the surgeon, if you understand the surgeon, just tell him, and if he wants to know, sure, why not? But in our practice, our surgeons only want to know if it's serious enough injury. So you can see out of 174, only 5 patients had EMG changes that clinically led to motor evoked potentials changing as well. So these are the good, the changes that you should have picked. So, but I'm not trying to suggest that EMGs are not a good test. What I'm trying to suggest is, yes, you keep an eye, but refrain from raising unnecessary alarm unless you really know what type of changes you're seeing in the EMG, and we discussed that in one of the previous slides. And again, we discussed that as well. Oh, it's not showing anesthetic changes, but as I told you, about 12 patients with anesthetic changes on that as well. Now, if you want to know the numbers, surgeons want to know the numbers. They want to know what is the probability of having this change. So I want you guys to focus on the the extreme right column. So probability, these are my numbers. You can argue you may have less numbers, you may have more numbers, but these numbers in general correlate with the international data. What I'm trying to show you here is that the surgical events are most likely happening in if you are doing a major thoracolumbar case. Anesthetic changes, about 6% chance that you may have an anesthetic change. So next time if your anesthesia asks, we don't contribute to your injuries, you tell them that there is a 6% chance you are contributing to our injuries. And then, a bad screw, at least one screw happening in a bad scoliosis. For example, you're placing 20 screws. The chances of having one screw bad can be high, especially in younger surgeons. If you are a young surgeon, and especially if you have a bad scoliosis higher than 90 degrees. Our worst scoliosis was 160 degree scoliosis, we state, but we don't, we don't feel shy of staging our scoliosis if we see a change, especially 120 degrees, 130 degree scoliosis. We do it in 2 steps, in 2 stages. So, and then, positioning changes, 2.8%. Similarly, at the bottom right, you can see that the probability of having an MEP change because of a bad screw is about only 1.6%. So, what I'm trying to tell you here is that these numbers are important. And if a new surgeon or a surgeon who does not believe in, neurophysiology sometimes, you might want to tell them these numbers, especially if he is doing a major spine surgeries. Now, just to show you some examples before we go to more cases. Now, here we have a scoliosis patient, and the top picture on the top left is hand muscle. Top right is again right side hand muscle. And if you see here the lower limb muscles, I have about 4 of them or 5 of them, and same things on the right side. Now, if you can see this, there is, you can clearly identify, remember we talked to you about the size of the wave. We call this amplitude, the size of the wave. Now, you see the size of the wave is dropping, but the reason I am showing you this slide, because we are not able to interact, that's why I'm just continuing with with the findings. This patient has just a drop in mean arterial pressure because of excessive bleeding. In our hospital, we use the tranexamic acid infusions, but I don't know about you guys, but here you can see upper limb is also dropping in a scoliosis case. Left side, even right side has some drop. So what I'm trying to tell you here is you don't want to go to the surgeon and create an unnecessary alarm. Surgeon is already stressed out. There is bleeding happening. He has a major correction to achieve. So just go to anesthesia and don't create unnecessary alarms. In this patient, we just went to anesthesia, and I spoke with him, and he increased the mean arterial pressure, and the signals recovered. And I hope you guys are able to understand why I'm saying this. This is not a surgical change, because upper limbs are also dropping. So this is, in a scoliosis case, upper limbs should not be dropping unless there is a drop in the blood pressure or mean arterial pressure or excessive bleeding. Okay, next slide. If you can see, this is the summary of motor evoked potentials data. Now, right, look. Yes.
We must come to the conclusion because we have almost 40 minutes. talk. Then we need some questions,
Okay,
discussions.
can I have 4 or 5 more minutes? Is that okay? I'll just quickly move on.
3
I'll
minutes.
quickly move on. Okay, 3 minutes. All right. Okay. So you can see here there is a drop in. I'm seeing the drop in the right side lower limb. As you can see, most of the other muscles are not dropped. So this is a root-specific change. This is not a cord change, not a spinal cord injury, but a root injury because only a couple of muscles are showing a drop. Quickly move on. I would also emphasize this patient. This is a fractured spine case. This is a cervical fractured spine case. Please always try and get the baselines before flipping. If there is a prone position or a posterior spinal case, get the data in the supine position, especially in cervical spine fractures. In that patient, we saw a change during flipping, so please do that. I'll quickly move on. Spinal cord mapping, if a good spinal cord, you stimulate the spinal cord using a monopolar, a healthy cord would transmit the signal and you record from the muscles at less current as the compressed or injured or not or is pathological, even a more current with certain parameters. I would not go into those details. That may result in blockage in the current spread, or there is no conduction at all. This is the concept of spinal cord mapping, which we do that frequently in our tumors. And just to give you an idea, a healthy cord, less current with a decent wave, bad cord or pathological cord, higher current, smaller wave, and even higher current still is not resulting in waves. It's a really bad or injured cord. Now, this is a patient. If you can see this, we have opened. If you can see, I don't know whether you can see, as I see, maybe there may be a lag, but this is on the fourth, and the right surgeon is on the medulla, you can say, or even on the fourth ventricle. And this was an intramedullary tumor and is working. See the top right, the top part, there is an opening already. There's the second myelotomy he's doing, and that is as he's removing this ependymoma. We would be doing sentries, motors, D-waves, and spinal cord mapping. So you can see the surgeon has too many tests, and he has complete assurance of what is going on in the spinal cord. I'll move on to the next slide. Pre and post-op mapping results. You can see this left and right side. There is a drop in during mapping, and what we did was we used 8 milligram dexamethasone and increased the mean arterial pressure, and the signals recovered in the mapping test. Now this test is for dorsal mapping, dorsal spinal mapping for spinal cord surgery. Remember, as you can see, I'm presenting to you this case because the patient was a gynecologist, and she presented with an intramedullary tumor. So see, she needed to have those proprioception skills in her hand because she's operating sometimes. So that's why in that patient I added the modality of sensory mapping, and I'll show you quickly. So see, I don't know whether you guys can see this. This is a bipolar stimulator, and I'm stimulating it. Now I'll show you what I'm trying to identify. Experienced surgeons sometimes identify the midline raphe, and they can open they can do the myelotomy easily. But sometimes it's not easy, especially in astrocytoma and especially in redo cases. In this patient, we were able to do dorsal mapping, and I'll show you the results, what exactly it looks like. You can see this here. This is the map. We stimulated the cord and we recorded from left brain. You can see on the top left. Then on the right brain, you can see here in the green. Midline should not produce a response on the scalp. I'm stimulating. This is one of the methods of doing spinal cord dorsal mapping for myelotomies. You see there is no response. This is the point where I would tell the surgeon to go in there and open the cord from there or myelotomy from there. I'll quickly move on. Again, a case of a tumor where we are seeing a D-wave persisting, but the motor wave potentials drop. We did not stop the surgery. We asked the surgeon to continue because we had the D-waves, and we did not stop surgeon prematurely. A lot of times surgeons would ask that you guys are stopping us and giving us not enough time, and we are doing suboptimal resection. So if you're doing multimodality and giving maximum modalities to the surgeon, very likely you should be able to do total resection or maximum resection. This patient, I would just like to show you the angio, spinal AVM. I hope you guys can see that. This is the AVM sitting on the spinal cord, and the surgeon, in the MRI also you can see this. The artery of Adamquist was in close proximity. That's why surgeon did not, the neuroradiologist did not embolize it because he was worried about the artery of Adamquist. So we opened it, and I'll show you the video here quickly. And these are some of my last slides, and I'm finishing it up. So see this surgery is very simple surgery. The surgeon is opening the cord, open the dura, sorry, and you can see the layer of arachnoid sitting, and then this is the AVM sitting on the cord. What we did in this patient, we just did somatosensory motors and we did the spinal cord mapping. We stimulated proximal to the cord, recorded distally, and we were continuously doing it, and the surgeon was able to identify the feeding artery to the AVM, and then that artery was with the use of ICG. I'm sure most of you guys are familiar with that. This is the pre-identifiable, and then he identified the feeding artery going to the AVM. He clipped that artery, and then we did another ICG. You can see that it's not filling up the artery. Surgeon was given assurance by our test that, a little bit filling there, by our test that, sensory motors are good, spinal cord is conducting very well, although it was close to the artery of Adamquist. So he had the reassurance and, the courage to do this without much issues. I'll quickly move on. Now remember this slide. If you are a surgeon, if one of the surgeons you're watching my presentation, please understand this. Your results will only be as good as your electrophysiologist. If you do not have a good electrophysiologist, don't believe electrophysiology. That's a problem is, for example, in your staff. So always, try for the best possible staff or a good training program. It matters. All the criteria that I've discussed briefly. And then, I would like to show you this. This is one of my templates. I am with the surgeon each step of the way. As he is placing the screw, I am doing motors. Right after each screw is placed, I'm doing motor evopotentials. While he's placing screws, I'm doing somatosensory evopotentials. What I'm trying to tell you is you're not sitting outside having a cup of coffee while the surgeon is doing instrumentation. You should be with the surgeon each step of the way, doing motors as much as you can, doing all the other tests as much as you can, and then only you would be able to identify changes quickly and then communicate it to the surgeon. This is my last slide. So, team is essential. Surgeon is, of course, have good rapport with anesthesia, and then your team of electrophysiologists. Always discuss the case with your team and anesthesia. Do multimodality, and then use relevant muscles. Maybe add 1 or 2 more muscles for the recording of your responses. Always include anal sphincter responses from thoracic or third port surgeries. If there is an anterior cervical spine case, do recurrent laryngeal nerve monitoring. And then I already discussed that fractured spine. Please do the baseline data before flipping, so you may be able to identify change post flip. So I hope my talk you were able to identify and it was helpful. So what exactly we are doing, instead of giving the top picture to the surgeon, we are giving the bottom picture. We're giving him a nice and bright and green picture instead of a gloomy, dark picture. So that's all we're doing, and the surgeon is taking care of the rest. Thank you very much. This is my last slide, and I'm happy to take questions.
Yeah. Dear Tariq, it was a great talk, really. I'm sure the participants enjoyed that also, and we learned a lot. First of all, I'm someone who are using regularly in intramedullary tumors especially. As I've seen, most of your examples were also intramedullary tumors. What do you think about usage of the techniques in other areas? Shall we use in most of the spine surgery, do you think?
So Dr. Zalili, especially if you are a younger surgeon, I would definitely recommend using in as many surgeries as possible in spine. But besides intramedullary tumors, in our practice we use it in thoracic tumors, we use it in tethered cord surgeries, and you'll be surprised a lot of times we are able to identify tiny rootlets around the phylum, especially if the phylum has lipomas and all things like that. So, it's very helpful in those cases. As I said, in the US, for example, all instrumentation cases, they're using monitoring. We are not doing that in, say for example, 2-level fusions in cervical spine or T-lifts or, L5-S1 fusions, unless the patient has pre-existing weakness, unless the patient has previous surgery already, and the surgeon is worried about those surgeries. For example, old age patients, OPLL patients, in those patients we do monitoring. In all spinal cord tumors, we're doing monitoring. Of course, ependymoma versus astrocytoma, there is a difference in results, and there is in total resection versus subtotal resection. But at least I can show you a few examples, but there is of time. We did 2 astrocytomas where, you know, we stopped the surgery. So my message is, yes, we can do more surgeries, but not all surgeries in good hands require neurophysiology, but definitely tumors, all types of tumors should be monitored with neurophysiology.
One question from the participants, Dr. Marina Schonwald is asking, we use vibration stimulation added to SEP for dorsal status. What do you think about the technique?
Yeah, I mean, you know, she's probably suggesting of the SSCP, as I told you, remember when I showed you some of the examples. If she's referring to instrumentation cases, I think she may want to focus more on motor evoked potentials. I'm sure she's doing that already. But, you know, the vibration for SSCP's depth of anesthesia, if it changes, you may not be able to, anesthesia is using very deep, you may not get responses. Similarly is the case for dermatomal SSCPs. They used to be, you know, used in the previous ages. Now, for example, if you have a foot drop patient and the surgeon is working on an L4-5 tumor, you may want to add, in addition to posterior tibial nerve, you may want to add peroneal nerve SSCPs as well. I would focus more on the electrical stimulation techniques rather than vibration stimulation techniques, because anesthesia takes, you know, some signals out because of depth of anesthesia. So instead of focusing on that, I think I would focus on electrical stimulation and motors, then dorsal or vibration stimulation technique for sensories, which sometimes does not really change during those surgeries. I hope I was able to answer the question.
Yeah. What do you think about it? The negative and fast positivity and fast negativity. Actually, as we know, fast positivity is not a big issue because it may stop the surgery. The surgeon may stop the surgery because the potentials have gone. But after surgery, no significant deficit happens. But the worst thing is fast negativity. You do not notice anything, but after surgery you see that there is significant deficit. What are the percentages of fast positivity and fast negativity in your practice?
Dr. Zalili, you might be probably not believe that I so far have not got about 1,000 cases we have done in our hospital in King Fahd Medical City. I have not so far seen a single false negative in my practice, and I will tell you the reason why. About false positive, remember I told you that if you see in spine, remember I'm talking about spine here, in spine cases the most important test that enables you to identify false positive and negative is transcranial motor evoked potentials. And as I told you, if you are working on a spinal cord tumor, for example, or even a thoracic fusion case, and you saw a motor drop, your technologist or your physician tells you that there is a motor drop. And if the motor drop drops below spine, you may think that, oh, he's suggesting that the patient may have deficits. But if you take necessary measures, increase mean steroids, and you know, we also use milrinone infusion, by the way, I'm not going to go into those details. But what happens is that this drop, if it exceeds and reach 100%, even then, you are not sure that this patient may have clinical power post-op of grade 3, grade 2, grade 1 or 0. So he's telling you that, oh, Dr. Zalili, I lost motors, flat lines now. The patient may still have grade 3 power post-op. So what I'm trying to tell you is, yes, false positive, and especially in tumors, especially astrocytomas, can be a problem. And what I suggest is to add other modalities. For example, if you're doing an astrocytoma with motor evoked potentials on flat lines, I would do D waves or I would do spinal cord mapping and then be able to tell you that it is really a cord has dropped down to paralysis or not. I hope you're able to understand. Motors has limitation. All these tests are very good, very sensitive, highly, the probability of identifying a change is very high, but there is limitation. So if you see a drop in spine case, 100%, that patient may stop with the power 3. Remember, if you have good signal, the patient should have power 4. So this false positive, if the surgeon, if the technologist or physician is telling you the power is, the signal is still there, and still you have 0 movement post-op, that is a false positive. That should not happen. In my practice, should not happen. The percentages are about 8 to 10%. In astrocytomas, there is reported data, but there is no data that, convincing data that talks about in scoliosis, for example. Actually, a Journal of Spine 3 years ago published a paper, and they presented a case of false positive, and the patient woke up fine. But actually, when the American Society of Neurophysiology Monitoring argued with the journal that actually the technologist mistakenly placed upper limb instead of lower limb, he switched the placement of electrodes in his system. So it was actually a positioning change happening in the upper limb, but it resulted as a lower limb change. But you're right, it should not happen with vigilant monitoring.
Okay. One more question Dr. Marina is asking. Is it possible to do mapping with lower intensity than 5 milliampere? We do 2 milliampere.
Yeah, so she is right. I only discuss one method. There are 3 methods of doing dorsal column mapping. In the motor mapping, what I was telling you about, where we were doing motor mapping of spinal cord with 5 milliamperes. The sensory mapping for dorsal column, we are also doing it with 1, 2, 3 milliamperes. In a patient, remember, you always have to, on one of my slides, I presented to you that you have to know the grade, clinical grading, McCormick grading of that patient before you start the surgery. If you have a patient with McCormick grade 3 or 4, you would not get a response at 2 milliamperes. I'm sure Dr. Marina knows that if you have a McCormick grade 4, you probably need to go 7, 8 milliamperes. So it depends on the clinical, presentation of the patient. If I have a patient with grade 1, likely 2 milliamperes of dorsal column mapping is a good response, and I'll get a response very nicely. Motor mapping may require higher. There are 2 more techniques of motor mapping, and maybe she's referring to that, and if I go into those details, I stimulate a 200 microsecond pulse, single pulse technique, and that's why you require a higher stimulation. If you increase the pulse width to 500 microsecond, you may reduce the current intensity, and you may get a response. So there are 2 more methods, but because of limitation of time, I did not get into that. But her idea of 2 milliampere for sensory mapping, I agree. But motor mapping, you may want to increase the stimulation. I have gone up to 20 milliamperes with single pulse with motor mapping with a McCormick grade 4 pre-op clinical picture.
Okay. One last question from me. As you know, during cryo stimulation, you get a movement of the patient. Then under microscope working, it's not, it's a terrible thing. It's like an earthquake for the surgeon. And sometimes surgeons do not want it for very tiny areas to work with stimulation. Do you think there is a solution for that?
Dr. Dalili, let me tell you this. Actually, if I think I'll probably take 2 extra minutes. What happens is your anesthetic level, if you are monitoring EEGs, this happens for 2 reasons, or maybe 3 reasons. One, the depth of anesthesia is not optimum. I would go into more technical details. My EEG, 4-channel EEG, I would prefer having 1 second of suppression with 4 seconds of burst of activity, which means that the brain is enough suppressed metabolically for the patient to not move too much. If the anesthesia is lighter and you have a lot of delta wave or faster delta wave anesthesia while you are operating, the patient is likely to move, number 1. Number 2, if the placement of electrodes, if they are going too lateral, in the homunculus, you see, the stimulation is happening because we're trying to stimulate on the motor homunculus. Our electrodes are relevant to that. So for example, if you're doing a spine lower limb case with thoracolumbar, I don't have to go lateral. I may bring my electrode stimulation electrode medial. So the current spread is between these 2 electrodes. That minimizes the movement. The third thing is technical thing. My stimulation, you would be surprised, Dr. Zalili, we do aneurysms with motor evoked potentials, and the surgeon does not even feel it in about 9 out of 10 cases. The reason is
that is asking, do you do MAP, MEP set 6 centimeters? You can read the question from there.
I think she's asking if I do a midline. Yes, yeah, I understood her question. She's asking, so see this, if people can see my picture, my video? Okay, so she's saying that if you pick a midline montage, this one, for motor stimulation, especially for lower limb, you have to stimulate deeper and that causes the movement. I do not do that. I just do, based on the surgery, if it's a face or brain surgery, I may have to go lateral. But if it's a spine case, I just minimize the spread of 2 electrodes, I bring them medial. So that reduces the current spread. The electrical field is less now. That minimizes current as well. I do not use CZ montages. CZ montage is a midline montage that requires much higher stimulation. I do not do that. I hope she is able to understand.
She's
writing something.
That's fine. No, thank you. Actually, it was really very descriptive and very nice lecture. I thank you a lot, and I thank all the participants to spend 1 hour with us without leaving us. Thank you all. I'm closing the session. Thank you, Tariq.
Thank you, Professor Lilly. Thank you, Professor Lilly. Thank you, everybody, for attending the conference. Thank you very much.
Thank you.
Multiple people saying something. Dr. Zalili.